Yukon Health. Um, and they asked me to talk to you today about the medicines that we use to treat seizures and epilepsy. So we'll try to do that as sort of as efficiently as we can, covering a lot of ground. But I'm sure typically when I give one of these talks and it's just for people in the community, there's a whole lot of questions. And so I don't want to talk so much about the things that I want to talk about that we don't get to talk about the things that you want to talk about. So please interrupt at any point if you've got a question. Just sort of say something and I'll hear you and hopefully stop talking and we'll question. So I have no conflicts of interest. Um, and so one of the things when I'm lecturing to medical students that I like to emphasize is that while the old-fashioned term for these drugs is anti-epileptic drugs, they're really not anti-epileptic, which means they don't do anything to the condition that causes the seizures, which is epilepsy. They just kind of suppress seizures and they prevent seizures from happening. So what we really mean is that they're anti-seizure drugs. And what they do in an ideal world is prevent seizures from happening without causing a whole bunch of other side effects. And so uh, what we try to do is choose the right drug to treat the kind of seizure disorder that we think the person has, and that have minimal side effects so that we get the seizure control that we're looking for, but we're not causing a bunch of other problems. So I like to show this slide as well because, and this is a little weird, but this skull was from an epilepsy patient from a long, long time ago, probably hundreds of years ago, from Central America. And that person probably had seizures. And we know that because somebody did this surgical incision and made a hole over the area of the front of the brain. And the reason they did that, and they used this very fancy surgical tool here, was to treat the seizures. And the way they treated the seizures was by making a window that would let the demons get out, because they figured that it was demons possessing you, seizing you, that caused seizures to happen. Fortunately, the patient probably survived at least a little bit because we see signs of healing on these wounds. This was what we would call a mechanistic approach to treating seizures. It's just that their understanding of what causes seizures is a little different from ours. So before we get started about talking about seizures and epilepsy and the drugs we treat them with, it's good to talk about what do we mean by epilepsy and what do we mean by a seizure. So when I say epilepsy, what I mean is that there is a tendency for seizures to occur in an unprovoked way. And those of you who have seizures know that you can't predict mostly when they're going to happen. And so that means your brain just has a tendency to produce these unfortunate events. And that's due to some problem in the brain typically. And sometimes we can see that problem on an MRI or an EEG, and sometimes we can't. But the assumption is that there is something about the way your brain is wired that produces these seizures. And so what is a seizure? Well, a seizure is an abnormal pattern of brain activity that occurs when brain cells do things they're not supposed to do. They get excessively excitable and they fire too much. They fire too excessively, they fire too rhythmically, and they fire too much together in synchrony. And those are the things that produce the things that we cause seizures, whether they're convulsions, big jerking seizures, or just bland staring spells sometimes. And there's a variety of different symptoms that can result from these discharges in the brain. Okay, so that's what we mean by epilepsy. So to understand how these seizure drugs work, you need to think a little bit about, well, what does the brain do to generate both seizures and normal activity. And that happens because these brain cells talk to each other. They communicate using chemical and electrical signals. Most of the signals are either excitatory or inhibitory, and the excitatory signals make other brain cells more likely to send signals on to other neurons. And most of the chemical they use for that is something called glutamate, and that acts at different flavors of glutamate receptor called AMPA receptors and NMDA receptors. And most of the inhibitory signals that make neurons less likely to send on further signals, that makes them less excitable, are using the chemical GABA, or gamma aminobutyric acid, and that happens at GABA A receptors, which is a kind of ion channel. There are also electrical signals, and those chemical messages get translated into electrical signals in the brain. And those typically work by opening and closing ion channels in the cell membrane, and the ion channels let charged particles, ions like sodium and potassium and calcium, or negative ions like chloride, to pass through the cell membrane, and that changes the excitability of the cell. Sodium and calcium ions, when they flow, they typically go into the cell and they're positively charged, so they make the cell more excitable. And potassium is also positive, but is mostly in the cell, so it goes out when the channel's open. That makes the cells less likely to fire. Or when chloride ions go into the cell, they make the cell less likely to fire. So those are inhibitory ions. And so seizures happen when there's an imbalance of excitation and inhibition. And typically there's too little inhibition, there's too much excitation. So most of the anti-seizure drugs that we have use ion channels or those chemical receptors that I was talking about as the target where they work. And those drugs either enhance or inhibit the function of those channels or receptors. And so that kind of gives you a little bit of introduction. So when I start talking about these targets, you'll know a little bit more about what I mean. So we got a whole lot of drugs these days that we can use to treat epilepsy. And this is an exponential curve of the number of drugs that we've had since way back in the first one in 1857, the bromides that didn't work very well and made you really sleepy, to a drug that we still use today is Dilantin or phenytoin. That's been in almost 100 years. 1937 is when that one started, and phenobarbital a little before that. Which is kind of falling out of use. There are so many other better drugs now. And then you get into the 70s and 80s. So that was sort of our first generation of drugs up through about 1960 with ethosuximide. And then there was a second generation of drugs starting with carbamazepine or Tegretol back in the mid 70s. And then for the last quarter of the century, we had, 8 or 10 drugs here that really sort of is the early modern period of medicines for treating epilepsy. And then the third generation of drugs has really kind of taken off. And a lot of these are sort of modifications of older drugs, like oxcarbazepine is a modification of carbamazepine, and so is eslicarbazepine. But some were brand new mechanisms like levetiracetam or Keppra, which has a completely different site of action. And not all of these drugs are in common use. Some of them have really fallen out of use for a variety of reasons. But we'll talk a little bit about how these drugs work and what they typically are used best for, and then kind of try to open it up to some questions. So with all these drugs, and particularly for the medical students, when I'm teaching them about it, they say, oh, 30 drugs, how am I going to remember 30 drugs? But it helps if you know what kind of seizures are helped by the drug. And that depends on what the drug's target is in the brain and what it does at that target. But so are the side effects. So a drug, for instance, that works on GABA receptors is likely to make you sleepy. And so if you understand what some of these drugs do, it helps you understand what the side effects are going to be of that medicine. Okay, so what I wanted to show here is that seizures, if you look at a recording of the brain, this is an EEG recording, and these are the wires that are sitting over the temporal lobe, which is a common place where people have seizures. And what you see is they start out really fast and low amplitude, and they get slower and higher amplitude, and change and evolve and spread to other places. And that's what seizures typically do. And interestingly, if you put an electrode into a rat brain and record a seizure, you see a very similar kind of discharge from the brain cells that are right in that area that's having the seizure. And so this kind of discharge requires a lot of very rapid firing. So a lot of the drugs that we have for treating seizures work on the ion channels that are used to create those action potentials, those firing spiky discharges that we saw in the last slide. And so this is a cartoon of that ion channel. That this is the membrane that it sits in, and it looks kind of like a donut sitting in the membrane with a channel in the middle. And here I'm showing a binding site for where the seizure drug, the sodium channel agent, might bind. And this little tail here is kind of a way to close the channel at the end. And so what happens if I have a little chemical, if we record from a neuron, it has these rapid action potentials, and its membrane potential goes from -70 up into the way positive area. But if we bind a drug onto that channel, it stabilizes the inactive kind of position or configuration of the channel, and then only a couple of these action potentials actually fire, and the rest of them get suppressed. And what that does is it makes the cell less excitable and less likely to have a seizure happen or spread. And so that's what the sodium channel medicines do, is they bind onto these sodium channels in the membrane and make them less excitable. So the sodium channel agents are very good for focal seizures, and those are the ones that start in a focus in the brain and then spread out and may cause either sort of the focal seizures with lip smacking and chewing and staring, and then can progress on to a generalized tonic-clonic seizure with stiffening and jerking. So those focal seizures are often benefited by these sodium channel agents, but the sodium channel agents do other things because some behaviors that we have, like aligning your eye movements or coordinating your movements, require that rapid firing. So when we use sodium channel agents, if the dose gets too high, we might cause double vision or something called nystagmus, jerky eye movements. We might have coordination problems or dizziness or even falling. And if the dose gets really high, people may get sleepy or their thinking may be slowed. And all of these problems are dose dependent and reversible. It just means there's too much drug there. And if we just lower the amount of drug, then things get better. So here are some of the drugs that do all of those things. The older drugs are the drugs like Dilantin, phenytoin, carbamazepine, which is Tegretol, valproic acid, which is Depakote, phenobarbital, lamotrigine or Lamictal, topiramate or Topamax. And then some newer ones, as I mentioned, oxcarbazepine is a derivative of carbamazepine, and so is eslicarbazepine. Medicines like zonisamide or Zonegran, lacosamide or Vimpat, rufinamide or Banzel, all of those are sodium channel drugs. They all work slightly differently, but differently enough that if one of these drugs doesn't work, we'll try a different one because they tend to be pretty effective for controlling seizures, at least the seizures that are of focal onset. So that's why we might try one drug. If we don't get the response we want or it causes problems, we'll switch to another drug that is in some ways similar. Some of these drugs have other side effects that are not dose dependent, like overgrowth of the gums in people who have difficulty keeping their teeth clean. There's a reaction that forms, and sometimes that has to be surgically corrected. Um, uh, Bone density can also be adversely affected, and you can get osteopenia or osteoporosis, and that can make your bones more fragile and likely to break. And so often when we give these kind of drugs, we'll also give vitamin D to help improve bone health. And so the occasionally drugs will cause an allergic reaction and you can get a rash. And if that happens, we just will stop that kind of drug and start a different one. So this is what the chemical formula of Dilantin or phenytoin looks like. Not that anybody really cares what that looks like, but it's kind of fun to see these different shapes of these molecules. Carbamazepine or Tegretol is a completely different. It has got 3 cycles, 3 rings as part of its chemical structure. And because it is broken down more quickly, you have to give it multiple times per day. Although it's also available in slow release forms so that you can take it only once or twice a day. And it has most of those same dose-dependent effects that I mentioned. Some people are more likely to get a rash from this drug, and it's particularly if people are of Asian extraction and have certain kinds of immune blood groups. We can actually test for that, and if people have this particular genetic trait, we will tend not to give it to them because it makes them much more likely to get a rash. Sometimes drugs like carbamazepine or oxcarbazepine can lower the sodium level in the blood, and that can get dangerous and cause seizures too, so we tend to monitor for that. Here we see oxcarbazepine, which is very similar to this one, except we get the extra oxygen there, and that changes the way the drug is broken down. And it makes it a lot more tolerable. So it can be dosed only twice a day, and we don't get the same side effect profile that we get with carbamazepine. It's much better tolerated. But one of the trade-offs, the low sodium, is a bit more common with that, so we have to watch that more carefully. And then the third generation is modified a little bit further. It's similar, but there's an extra group on there, and that keeps it in a very specific configuration that is, instead of having forms that stick off in one direction, it sticks off only in a single direction rather than both directions, and that makes it a bit more effective. And this is also broken down more slowly, so you can dose it only once a day, and that's an advantage for some people. Depakote or valproic acid is a completely different shaped molecule. And it has a variety of different channel effects. It works on sodium channels. It works on a specific flavor of calcium channels that seems to be involved in absence seizures, a type of generalized seizure that has staring spells, often in children. And it may do other things as well. It is useful also for things like mood stabilization. The psychiatrists love it for bipolar disorder, but it has a variety of other problems as well. It's broken down mainly in the liver, so it can cause liver problems. It can make people gain weight, unfortunately, not by the drug itself. It just makes you hungrier, and so you eat more and gain weight. It can cause a tremor sometimes. It can cause some hair loss. And the liver problems can cause jaundice. And so that's a pretty rare complication and mostly seen with high doses and in combination with other medications. It also isn't good for women of childbearing age because it can cause birth defects. So we try to avoid giving it to women who might get pregnant. It's really not good for babies' development. To some extent, we can reduce the odds of that happening by giving extra folic acid. That's a vitamin, a B vitamin, um, but not completely. And that's why if we can avoid that drug in young women, we tend to do that. Another drug that's very commonly used is lamotrigine. It's also a sodium channel drug. And it is also broken down in the liver, and it has these weird interactions with Depakote. So if we were to give both of those together, the Depakote kind of prevents the lamotrigine from getting broken down. And so that means the levels tend to pile up, and it can cause toxic kinds of symptoms. And so we have to be very careful about that. And whenever we use more than one drug, we often will check the levels of all the drugs to make sure we're not causing trouble because of these kinds of interactions. Lamotrigine used to be famous for causing rashes like this. This is a typical kind of drug rash. And that rash can actually be dangerous sometimes. It can cause a syndrome called Stevens-Johnson syndrome, where the skin is very gets sick and can cause other problems. And so we tend to watch for that very carefully. At the first sign of a rash, we typically will stop the medication and change to something else. But other than that, what we've also found is that if we start this drug really slowly and very gradually ramp up, the incidence of rash is much lower. So it's a pretty safe drug these days. Another drug you may have heard about is topiramate or Topamax. It has a really complicated structure here, including this sulfonamide group. It is also useful for focal and generalized tonic-clonic seizures. It works at sodium channels, but it also seems to have some effect on the inhibitory GABA currents. And that may add to its efficacy. It's another way that it can be helpful for controlling seizures. Interestingly, it was found out pretty early on that at low doses, topiramate is also useful for keeping headaches away. And so we use it sometimes at lower doses as an anti-headache medicine. It has a variety of other side effects, some of which are not too pleasant either. So we got to be careful about those. It can cause sort of this tingly feeling in the fingertips and the toes. It can cause confusion. And back when it was coming out, people sometimes had the nickname Dopamax because it made people feel dopey. Most of these we can avoid by going very slow when we ramp up the dose of topiramate. The one real deal breaker is we try not to give it to people who get kidney stones because it can increase the chance that you're going to get a stone, and nobody wants another kidney stone. How are we doing? Are there questions out there about what I've said so far?
Yes, you have 2 questions here.
Okay. So,
The first one is, do sodium blockers often need additional drugs to be used at the same time?
So it really depends on the kind of seizure disorder. Sometimes when we don't get the complete seizure control, we'll add on another medicine. And the choice of medicines, often we will, when we choose a second medicine, we might choose something that has a different mechanism of action. And the idea is, and it used to go by a fancy name called rational polypharmacy, which I don't know how rational it really is, but the idea is you got 2 different ways that you are working to control the seizures that that might be beneficial. So sometimes we will choose a different mechanism. And part of the reason for doing that is if we have 2 different sodium channel agents together, the chance of causing sodium channel toxic problems like the double vision or coordination problems or sleepiness is much worse. And so that's another reason for choosing one that has a different mechanism. So what's the second question?
And the second one is a little paragraph before the question. Partial complex from occipital lobe scar tissue, lamotrigine, stonosamide, clozapam, paroxetine. Valium for recovery. Seizures presented as lip smacking, looking up lights, zoned out, last for less than a minute. Seizures have changed to psychotic, seeing things not there, distorted vision, looking how large my hands are, talking out of context, and major confusion. Is there evidence of long-term effects of taking the above medicines? I suspect PNES.
Okay. Well, that was a really long question.
Yes.
I'm not sure exactly where to go with all of that, but it's certainly possible that, if there's a scar on the brain, that makes it more likely that there might be seizures coming from that scar. So we always worry about that. Um, and, you know, we get fooled all the time about what seizures look like. In fact, it's one of those fun games that epilepsy specialists play. We show videos and people say, that has to be a non-epileptic seizure because it looks so weird. And then we find out that it actually was caused by seizure discharges in the brain, and others that look very classic and turns out that they're not epileptic. So we just don't always know. But I think that we tend to try to investigate, and that's one of the reasons that we'll often do either ambulatory EEGs or admit people to the epilepsy monitoring unit so that we can figure out what kinds of seizures they have, and that tells us a whole lot more about which drugs might work best.
Okay.
Okay, so what's the average dose of lamotrigine? It varies. It depends a little bit on what other medicines you might be taking. Usually, if it's lamotrigine by itself, we try to get up to at least 200 milligrams a day, so 100 twice a day would be a typical dose. If we get more than 400 milligrams in a day, a lot of times we start to have problems. But it can cause, everybody's different, and that's why we tend to ramp up the medicines until we get seizure control or we start to see problems, and that's when we start thinking about different medicines. Does lamotrigine cause memory loss? I wouldn't say by itself, but at high doses, maybe you don't think as clearly, and that ends up being a real problem because sometimes we wonder, is this a toxic effect of the medicine, or is it the seizures that are causing the memory loss? Because seizures can certainly do that. And that's one of the reasons that we'll tend to do this kind of monitoring, because it can be unclear whether the problem is the amount of medicine or that the seizures are being not as well controlled as we think they are. I'm seeing some other questions. So what do you recommend for what presents as benign Rolandic epilepsy, but 59 seizures in less than 2 years on an 8-year-old? So complicated question, and I'm not a pediatric epileptologist, but usually benign Rolandic epilepsy is pretty easy to control with standard doses of standard medicines. And I think whenever you see a condition like that where the standard medicines at standard doses are not controlling them, we have to sort of call into question, do we really know what that diagnosis is? And maybe that's time to reevaluate and maybe even do some monitoring to find out, what kind of spells those might be. Okay. This is Coral's question. I've had seizures since I was been little. What are some good medicines to switch to? Currently on 2 different seizure medicines. I will send the slideshow onto the Epilepsy Foundation, and they can send out to everybody. I think that's going to be the most efficient way to do it. It really depends, and that's why I would ask that question to your epilepsy doctor, because they know the whole story and what type of seizures they are assuming you have, and they can give you some options. And sometimes the options are also devices like vagus nerve stimulation or even epilepsy surgery if you're not responding to medicines. And often when people have failed good doses of at least 2 medicines that were the right medicines for the type of seizure that you have, that's when we start thinking about epilepsy surgery. So I see, is 500 milligrams a high dose? And so the answer to that is yes and no. So yes, it's a high dose if that medicine is clobazam. That would be a knock you out of the park medicine dose. But if it's Keppra, it's a low dose. We start out with 500 milligrams. So when you ask that question, you have to know what the medicine is, because the doses of medicine depends entirely on what it is the dose of. And so just number of milligrams does not tell you anything without knowing what the medicine is. Okay, why do breakthrough seizures occur when using 2 different medicines? So that all depends on how difficult the epilepsy is to treat. And so, we will start with one medicine and maybe do sequentially one and then another. But if we're not getting the kind of control that we want, then we start putting 2 together and seeing if we can get a better result. But the fact that seizures don't respond, usually that tells you more about the seizure disorder, that it's a difficult to treat seizure disorder, than it does necessarily about the medicine. Except one situation, I've had a number of patients where they got treated with high doses of certain medicines like carbamazepine, but when we did the EEG, we found that they had a kind of epilepsy that was not well treated with carbamazepine. So for instance, there's a seizure disorder called juvenile myoclonic epilepsy that some of these medicines actually make it worse. And when you treat with the right medicine, and those are typically medicines like valproic acid or Keppra, then the seizures can be very easily controlled. So that's why it's important to do the studies that you need to do to try to find out what kind of seizures they actually are. And then you're more likely to be able to figure out what the right drug is. Okay, from Fabricio, I've had 4 seizures in a few months while taking 450 of lamotrigine. So, that's a pretty high dose of lamotrigine. And so I think your doctor would have to figure out what level you're getting with that dose. And so that's why we check levels. And then also determine whether you're having side effects on that dose. And if the level is low, or if you're not having side effects, then sometimes they can go up on the dose. And if either you're starting to have side effects or the level's pretty high, that may be a sign that maybe lamotrigine's not the right medicine. We need to try something different. Okay. So I think, again, I can't say with this, specific to you. What I can say is that's a great question for your doctor. And so the next time you see your epilepsy doctor, you should say, I've been on this medicine. These are the side effects I'm having, or I'm not having any, but I'm still having these seizures. What's our next move? Okay. Recommended medicine for a motion-triggered seizure. I'm not sure the last part. Seizure res. Was that supposed to be just part of seizures? Typo. Got it. Okay. So emotionally triggered seizures, that's tough. And that's one of the reasons that we tend to do the epilepsy monitoring, because on the one hand, there are non-epileptic seizures, and those are usually responses to stresses that come out in unusual ways. And so when those kinds of seizure-like things happen and we don't see the electrical discharges in the brain, then we start to think, well, maybe these are non-epileptic kinds of seizures, and they don't respond to seizure medicines. Sometimes they are helped by treating any other things that make you vulnerable to stress, like depression or other kinds of psychiatric things. And sometimes the best thing is cognitive behavioral therapy, because it helps you understand how those stresses are affecting you better. So those things, sometimes more than medicines, can be helpful when it's a psychogenic kind of event or a non-epileptic kind of event. They look like real seizures. They're not under your control. And that's one of the reasons that it's really important sometimes to monitor in the epilepsy monitoring unit to find out what kind of seizures these are and whether medicines are really appropriate. Seizure medicines are going to help this or not. Okay. My son was taking 2,100 milligrams of Oxtellar and 4 milligrams of Fycompa and still had breakthroughs. So again, hard for me to say. If the seizures are far apart, that makes it really difficult for your epilepsy doctor, because when seizures are close together, we know they're not working very well. But if we have to wait 10 months to figure out whether you're going to have a breakthrough seizure event, that makes it harder to know what we need to do next. So again, yet another reason to work really closely with your epilepsy doc. Keep in touch about number of seizures, how often, and side effects that you might be having. Okay. Okay, Christina's on track, is working on getting CBT. Excellent. Okay, other questions, or shall I keep going? Or okay. I think we're good for now. I'm going to try to cover a few more medicines, and we'll see what we get. So we've talked mostly about sodium channel medicines. There are those that work on excitatory synaptic transmission, and those work in a couple of different ways. There are some that seem to work on calcium channels that trigger release of neurotransmitter from these little vesicles. And those are medicines like gabapentin and pregabalin or Lyrica. And how they work exactly is not clear, but they seem to prevent excessive release of the neurotransmitter. There are also medicines that work on a protein on the vesicle itself called SV2A. The SV is synaptic vesicle. 2A is 2A. That's just the name of the protein. And that's where the binding site is for medicines like Keppra, levetiracetam, and its sort of related drug, brivaracetam or Briviact. And again, the way that seems to work is by preventing excessive release of the transmitter in these vesicles into the synaptic cleft and causing excitation on the opposite side. There's also medicines like perampanel, which is Fycompa that we just heard about in another question, that blocks these receptors, AMPA receptors, to glutamate on the opposite side. And that can help prevent this excessive excitation. Little bit of problem with perampanel is occasionally that can cause other reactions, kind of psychogenic reactions, paranoia and hallucinations and things like that, particularly at higher doses. But just something to be aware of. So gabapentin and pregabalin are typically pretty well tolerated drugs. These are the ones that work on this alpha 2 delta subunit of the calcium channel. We use them some for treatment of focal and generalized tonic-clonic seizures, but they're much more used for neuropathic pain disorders. They seem to work really well for that. The good news is these medicines are pretty well tolerated, and sometimes we use them as adjunct medicines. We use them in addition to other medicines that are more standard. Keppra is a drug we use a ton of these days for a couple of reasons. It's very well tolerated. It seems to work for a variety of different kinds of seizures, both focal onset seizures and generalized onset seizures, and particularly for myoclonic muscle jerk kinds of seizures. And most people tolerate this really well, but a small percentage of people, maybe less than 10%, it makes them irritable and angry and mean. And usually their family says, get them off this medicine. They're intolerable. And then we do. Fortunately, the related drug, brivaracetam, which is similar to this, but it binds much more tightly, meaning that you don't have to use as much. It's much more specific, and it doesn't cause some of the personality effects that we see occasionally with Keppra. A small percentage will also get sleepy or weak feeling on Keppra, but that tends to be a really small percentage of people. Otherwise, these drugs are really well tolerated and they have broad usefulness in a variety of different types of seizures, which is why we use so much of it. Okay, so the third mechanism is enhancing inhibition. And so that is the chemical mostly responsible for that is GABA. And GABA is released from inhibitory nerve terminals, crosses the synaptic cleft, and works on these funny looking receptors called GABA receptors that have multiple different subunits. And the spaces between those subunits are where the benzodiazepines, drugs like diazepam or Valium, Ativan, or lorazepam, they bind in there, and they tend to increase the firing of the channel. And barbiturates tend to increase how long the channel stays open, and that allows more chloride to enter the cell, and it helps hyperpolarize the cell so it doesn't fire action potentials, and that's how you help prevent seizures. There are other ways to work on the GABA receptor. There's a medicine called tiagabin. Doesn't get used very often, but it prevents the reuptake of GABA from the synapse. And then vigabatrin or Sabril prevents the breakdown of GABA in the synaptic terminal, and that can also be beneficial, though it has some problems associated with it. Okay. The benzodiazepine medicines are those like clonazepam or Klonopin. These are medicines like Valium and Ativan, but these were designed more to be seizure medicines. So they enhance GABA inhibition, but they cause typically sedation, occasionally memory problems. We usually give these at nighttime when we are using them as seizure medicines so that the sedation happens when it's useful, helping you get to sleep. Clobazam seems to be much more general use. It was originally approved for a rare syndrome called Lennox-Gastaut, a type of epilepsy with mental retardation often, and multiple types of seizures. But it's found that it's useful in a variety of different settings. It's broken down in the liver. It has a long half-life, so it's only dosed once to twice a day. One of the things that we have to be careful about is if we add on the medicine cannabidiol, CBD, which is another medicine used for seizures, derived from marijuana, that can really prolong clobazam and can make people very sleepy. The medicines diazepam and lorazepam we really only use in the acute treatment of either status epilepticus, which is seizures that don't stop, or very frequent seizures when we want to break up a train of seizures from happening. The reason for that is they both make you very sleepy. I get the idea there are more questions, Amy. Are there more questions?
Yes, but we can wait till you're done.
Okay, let me just take a peek because I don't want to let them go too long. So will the DMV ask me if I have seizures and how should I handle that? The DMV, you typically have to tell them if you're having seizures. If you tell them, then they may want you not to drive for a period of time. And so, but they don't usually ask until your license is up for renewal. And so the way I usually handle that is I tell patients not to drive, but I also tell them I'm not going to tell the DMV because I don't want you to have to reapply for your license. My perspective is that, this is part of your treatment is, to uh, do things for your own medical health. And one of those things is if you're at high risk for having a seizure, then you shouldn't be driving because you don't want to get in the car and have a seizure and die. So when I suggest that you not drive for 3 months or 6 months or however long, that is between us, not between you and me and the DMV. Now, if you get caught because you had a seizure and you were driving and the police find you, they may yank your license and then you have to deal with that. And we will help with that once it's clear that your seizures are under good control. But then you have to sort of follow the DMV's rules, and they'll tell you what you need to do to get your license reinstated. Okay. Coral asks, I want to be on one seizure medicine. What is the best way? Again, take that up with your doctor. If you're well controlled on two medicines, sometimes that's a chance that you could go down to one medicine. And so that's, again, something you want to explore with your doctor, whether there is, that's an option for you. And I would always do that under the guidance of your doctor. Because you don't want to be making those decisions yourself and then wind up in trouble because you didn't do it in the way that would have been best for you. And Fabricio asks, does taking lamotrigine twice a day or extended relief make a difference in the effect? Ideally, it doesn't make a difference, but it's sometimes necessary to check levels more carefully with a slow release type of product because sometimes with a slow release, you don't get the full effect of all the milligrams. If you're taking, say, 400 milligrams a day in a slow release preparation versus 200 twice a day, you may actually get more medicine with the 200 twice a day than with the slow release 400. So important to kind of follow that and make sure that it's working equivalently for you. Okay. So shall I go back and go a little longer? We got about 10 minutes left of what we had originally budgeted for this. I'm going to skip phenobarbital. There's almost nobody on phenobarbital anymore. Only a few people on ethosuximide, which is only useful for absence seizures. It does nothing for focal seizures. And zonisamide, Zonegran, probably doesn't get used as much as it should be in this country. It's really nice because you only have to dose it once a day, and it's useful, again, for a variety of different types of seizure disorders. It can, like topiramate, because of this funny sulfonamide group, cause dizziness and some memory problems and kidney stones, and so we have to watch that. So it's a little like topiramate in that way. Topiramate has the added either bad or good side effect, depending on how much you weigh, can help with weight loss. So sometimes we use that if people also have weight loss as a goal. Some of the newer drugs, lacosamide or Vimpat, is a sodium channel drug, but it works a little bit differently. And Banzel, rufinamide, has some slightly different effects at the sodium channel as well. And so we will sometimes try these when the other sodium channel agents are not useful. I mentioned cannabidiol. It is actually derived from the cannabis plant, but it's a different strain, and this has no psychogenic effect. It does not make you high, but it does, for a lot of people, really add to seizure control. And so we will sometimes try it if we've been unsuccessful with other medications. I should mention that this is not the CBD that you can buy at the corner store. The reason that we use Epidiolex and not some of the others is that this is very rigorously controlled for how much cannabidiol is actually in the preparation. And you just don't get that kind of control with products that you can buy off the shelf. We mentioned Fycompa or perampanel. This works on the glutamate receptor, AMPA receptors. Has a very long half-life, so it's once a day dosing. But it can cause these violent thoughts and violent behaviors, so we have to really watch for that if we're going to use that medicine. There's a medicine that's no longer out called ezogabine that worked on a potassium channel. It actually opens the potassium channels, and it's a very different mechanism. Problem was this particular drug caused some urinary retention, and interestingly, it for some people caused their skin to turn blue. And that was because the drug would actually get stuck in the skin. It got irradiated by sunlight, and that changed its configuration, and that caused some blue staining. And the blueness itself wouldn't have been so bad, except it also caused problems because you'd get the blue in the retina of the eye, and people had vision problems. So that's one of the reasons that drug isn't out anymore. But there are some newer drugs that are coming on the market that use this same mechanism and don't seem to have any of these other problems, and they are kind of promising. The latest one that is really exciting is something called cenobamate or Xcopri. And this is derived or similar to an older drug called felbamate that we hardly ever use anymore because it had some real liver and bone marrow toxicity problems. But the interesting thing about this medicine is in most clinical trials, we get maybe 2 or 3% of the patients in the trial will actually have completely blocked, the medicine completely blocks their seizures. So they get 100% seizure control when they're on the medicine. And we're pretty happy with 1 or 2% because these are usually people in the trials who have very difficult to treat seizures. But in this trial, 21% of the patients on this medicine achieved seizure freedom during the trial. So that, suggests that this is a very effective medicine. It does have some problems like coordination problems and dizziness and sleepiness and double vision for some people. But, we escalate the drug very slowly. It's a once a day medicine. And it's really worth trying for a lot of people who have difficult to treat seizures. So it's one of those that we're keeping our eye on. Just a few things to wrap up. When do we start a seizure medicine? Typically not after a single seizure because we just don't know the likelihood you're going to have a second seizure. But if we see signs on the MRI or the EEG that suggest you're at high risk, like you had a problem, an old scar in the brain, or the EEG shows spiky discharges, that makes us much more suspicious you're going to have more and we might go sooner. In women, certain drugs like Depakote increase the risk of polycystic ovary disease, and so we tend to avoid them. And some drugs impair calcium metabolism, and that's why we give extra vitamin D. For women who are pregnant, we want you not to stop your seizure medicine. That's message number one. Even though there is a slight increased risk of birth defects in kids who are born if mom is taking an anticonvulsant, the risk is much worse if you actually have seizures. So it's worth, usually if we can plan this ahead of time, we avoid some of the medicines like Depakote that are have a higher association with seizure medicines. But in general, we recommend continuing the seizure medicine through the pregnancy. And we actually follow it over the course of the pregnancy because as you gain weight and fluid during the pregnancy, the levels tend to go down. We need to actually increase your dose during the pregnancy and then afterwards bring it back down as your weight changes after the birth. And when can we stop a seizure medicine? There are some predictors. If the longer you're seizure controlled, if you're on a single drug, and if we don't see other problems on the MRI or the EEG, you're much more likely to come off the seizure medicine successfully. But there are some conditions like juvenile myoclonic epilepsy that these are really lifelong genetic conditions. And can have perfect seizure control for 20 years, but as soon as you stop taking the medicine, the seizures come right back. So that's all I had. So let's go back to the questions. I see Liz says, I came in late. Sorry if it was asked already. Son occasionally drinks alcohol. Does it make seizures more likely? It really depends on what kind of seizure disorder he has. So I just mentioned juvenile myoclonic epilepsy. That is one that tends to be triggered by alcohol, interestingly enough. And so it's really unfortunate because what do young people like to do? They like to go out and have fun and go to parties and drink alcohol. And what they find is after their party, they have a seizure. And so they pretty quickly learn that that's not a good recipe. And so, but for other seizure disorders, what I usually tell patients is watch what happens. If you can, for most people, 1 or 2 drinks is not the end of the world. It is not going to cause breakthrough seizures. So moderation is usually fine. The only case where that tends not to be the case is things like juvenile myoclonic epilepsy. So can we get copies of webinars we've missed? I will leave that question to Amy. I am sure she'd be happy to provide that for you.
Yes. So all these webinars are recorded and on our website. So as soon as this webinar is done, we will post it on our website under the Ask the Expert series.
Okay, and it is just about 6:30, which is how long we were going to budget. Oh, I see Fabrizio's got another question. Matt, Lamotrigine. 500 is up there, but I've seen people on more. It really depends on how you're tolerating it. If you're having problems with it, let your doctor know. But some people can tolerate more and need more. So it really is an individual thing. Anything else? Okay. Well, it has been a pleasure. You guys have been a terrific audience. I love all the questions. And I hope we can do this again.
Thank you, Dr. Greenfield. I feel like this was very helpful.
My pleasure. Take care, everybody. I'll
Okay,
stop.
have a good night, everyone.
Good night.